Okay. All right, so I believe yesterday, so I'll throw out a couple of questions for you guys. Let's start with that. Yesterday we covered sensory stuff. We didn't get quite to the eye. We talked a little bit about the elderly, and usually one of the first things to go with them is hearing. And what is the hallmark sign that you would see an elderly person display if they're having hearing difficulties? Okay, confusion maybe, but okay, having folks, so how do they normally ask a person to repeat what they're saying? What do they usually do? Lean in is one, and then usually, yeah, or they put their hand on their ear and they'll say, what did you say? So that's usually the most common sign that you'll see related to elderly having some, or potentially starting to have some type of hearing deficit. The other thing you might want to consider is, if they do have a hearing deficit, then how would you communicate with them? So there's several options that you can use, like you put your stethoscope or a disposable stethoscope in their ears and then put the bell to your mouth, but don't scream into the thing because, as you know, that would be very, very sensitive. A communication chart, that would also be something that you can do. Pen and paper, that's something else you could do, but just understand it's going to take you a little bit longer to collect your information. So basically when they put their ear towards your direction to converse, then this kind of lets you know that maybe there may be a hearing deficit if it hasn't been notated already. And when should we start looking for, if we're going to go to the other end of the spectrum? So if you're looking at kiddos, how do we identify with children that they may have a hearing deficit? How soon should that start? Okay, so when would be a good time to even test for a kiddo, a hearing test? When should we do that on a kiddo? Newborns. So we should basically be looking to see if they're tracking noise. They try to imitate sounds, and that's usually the first step of them developing some type of language. And so it's important to identify those things earlier, those abnormalities early. So if there's like a loud crash, most babies would turn just like any regular human would. And if not, then that might be a hearing deficit. So just kind of, go back and look through RISI that, hearing test is important so that if they can't hear, it's going to be very difficult for them to develop the language. Okay. What can you tell me about Meniere's disease? And how does that, get going? Does everyone get Meniere's disease? Or is that just in certain people? How does Meniere? Okay, so no, everyone doesn't get Meniere's disease. What is it? Someone says, hey, I heard a word about hearing and it's called Meniere's disease. Can you explain it to me? What would you say? You're too bad, too sad. You'll never hear again. I mean, what would you say? Air pressure in the ear that's uneven, okay? And they get dizzy, okay? So can't people get dizzy from medications too? So how would that differ? How would Meniere's disease be any different than people that, may get dizzy from medication? Okay, one ear, all right. One ear is usually impacted or affected. Too much fluid from what? Okay, so name a couple of different things. So if I'm your patient and I've been diagnosed, and if you have a patient, I don't want to put this on myself. So if you have a patient and they have just been diagnosed with Meniere's disease, and the patient says, what is that? Can you tell me more about it? What would you say? And you can bullet point it. You don't have to do sentences, but just bullet point. Okay, so I know nothing about vertigo. So how would you explain that? So I want layman's terms, because then if you get it in layman's terms, it'll be easy to do the medical component. All right, so it's a condition for which you are experiencing dizziness, okay? And you feel like the world is spinning around. Okay, I can go with that. What else? The fluid in the ear is fluctuating. Okay, so explain that. All right, so, uh-huh. All right, so so look at it this way, start where the problem starts. So the problem, is it a middle ear, inner ear, outer ear? What kind of ear problem is it? So it's an inner ear issue. And you're right, it does affect one ear. That is correct. Okay. It can be caused by pressure or pain in the ear. They do have dizziness or vertigo. They do have hearing loss and a ringing sensation, which is tinnitus in the ear. So is that usually seen in kiddos or is that seen in adults? So it's seen in primarily middle-aged adults is usually when you see it. So they're more likely, your 40 and 50-year-olds are more likely to see it. So it can be considered chronic. Is there a cure? Can we cure Meniere's? No, there's no cure. But we do have treatment strategies to kind of minimize some of the effects that folks will experience. So they have these sudden dizzy spells after having that ringing sensation in the ear or a muffled ear sound. And it does vary from person to person, how many attacks they're going to have, how long it's going to last. So we don't have those, we don't have any factors on that. So they can't trigger or find the exact trigger point or the exact cause, but there is some belief that it has something to do with high pressure fluid in part of the inner ear. So the passages and cavities that connect throughout the inner ear, like the labyrinth, the outside of the inner ear is, where the bony structure is. So while the interior is soft membrane, the outside is a little bit more tough. So here we have tiny sensors in the ear that, that resemble hairs, and they can respond to movement and fluid and all of those things. So potential triggers would be like a head injury, allergies, an infection of the inner or middle ear, which is basically the otitis media, alcohol use, stress, anxiety, fatigue, family history, upper respiratory infection. So all of those are risk factors or things that can actually trigger an individual developing Meniere's disease. So, there's different staging of Meniere's. There's an early, middle, and a late stage. And usually, if it's in the early stage, then they're going to have this sudden or often out of the blue episode of feeling dizzy, and that can last from 20 minutes to the entire day. And they may feel like the ear is blocked or full, or they may have some hearing loss. But is that a sensory neural loss, or is that a conductive hearing loss when we're talking about this early stage? Because remember, there's two types of hearing loss. One is conductive, and the other one is sensory neuro. This would be conductive. Okay. So the patient, it depends. They may have the tinnitus, etc. As we get to the middle stage, then the vertigo tend to become less severe during that stage, but the hearing loss and the tinnitus will increase. So now we have more hearing loss than what we had in the early stage. So they can also have long-term remissions related to that can last several months before they have the next episode. The latter stage or the late stage of Meniere's, they will not suffer from vertigo as often, and some people may be relieved from that, from having the vertigo sensation completely. However, the tinnitus and the hearing loss will more likely be progressively worse, and people like that will have an unsteady gait, and so that one I'll put them at risk for falls. So this is the reason why that late stage of Meniere's is pretty significant. If they're in dark situations, they'll become significantly unstable, and their bearings will be completely off. So treatment options, sometimes they talk about salt intake that can help the body retain water so it can reduce the intake of sodium-rich beverages and foods. Decreasing caffeine would be good, eliminating foods that have MSG, which is the monosodium glutamate. Eating smaller meals more frequently. Smoking cessation, so basically stop smoking, and then manage their stress better. So those are some key things that can be done to help assist with an individual that may have Meniere's disease. Does that make sense? So if you have a patient that's been diagnosed with Meniere's and they're hospitalized, then what would be a good thing to do as far as interventions? Should you let them walk on their own? No. What about help ambulate? Okay, fall precautions, absolutely. What about, do you continue to assess for hearing loss since they've already been diagnosed with Meniere's? Yes, you still want it because we have 3 stages, so we want to see exactly where the individual is. Should we talk really, really soft? No, we don't want to talk soft because then the patient can't hear what we're saying, right? we don't have to be screaming bloody murder, but we don't, keep in mind, we don't have to be whispering because that's going to make it more difficult. And then should you be facing your patient when you're talking to your patient? Or should you be, looking all around and every place else? So make sure that you're facing the patient. So don't turn your back or don't turn your face to the side. That'll make that communication very difficult to ascertain for the person that's suffering from that. Okay. So any questions about Meniere's? And if not, then we'll just talk about hearing loss overall. So I mentioned a little bit ago that there's conductive hearing loss, and then we have sensory neuro hearing loss. And usually if it's conductive, there's some kind of blockage. So it could be fluid. It could be related to an upper respiratory infection. It could be related to cerumen in the eardrum. So, some people have a lot of wax build up to the point that it'll dry right in front of the eardrum, and that will prevent the individual from hearing really well. They can get something called cholesteatomas. They can have an otitis media. They can have a serous otitis, which is basically serous fluid versus a bacterial process. It could be trauma, a tumor. So if you get punched in the ear, you probably would have a conductive hearing loss unless there's been some type of nerve damage. Hence the sensory neuro. Sensory neuro is more, there's some damage to the nerve where it could be aging, it could be atherosclerosis, it could be drug toxicity, a head or ear trauma, impairment of the cochlea. So there's different reasons why Meniere's disease is actually not conductive, is actually sensory neuro. It could be presbycusis, which is the early stages of aging. So it is the early stage, or the first sign is where you have the I can't hear you. So that could all be sensory neuro loss. So it's things that you can't change. That would be sensory neuro. So that's why Meniere's falls under sensory neuro and not conductive as a whole. So what's actually happening to the ear? So if you have conductive hearing loss, what's really happening? Are we getting good sound waves? Are they able to go all the way through, or we have some type of disruption? And we're just speaking on conductive. So the sound waves are interrupted, okay? With sensory neural hearing loss, then the sound wave transmission is interrupted between the inner ear and the brain. On conductive, it's an interruption between the external canal and the inner ear. So as you go through the ear itself, then from the external portion to the inner ear is where there's a blockage. Once it happens from the inner ear all the way to the brain, then that's considered sensory neural loss because you've lost the acoustic nerve function, or you may have cochlea damage. So that's the reason why. With mixed hearing loss, a conduction dysfunction and a sensory neurotransmission are combined. And then with central hearing loss and the auditory brainstem responses are actually disrupted or distorted or absent. So just make sure you go back through Lippincott and review how the two different types of hearing loss happens. All right, so I've kind of given a history or risk factors related to either one of the losses: ear infection, chemical agents like chemotherapy, autotoxic drugs. So if there's a drug that you're giving a patient and it says autotoxicity, then the first thing you're going to be looking for is the patient to become or to have hearing loss or ringing in the ears. And there's certain medications that can actually do that. Oops, sorry about that. My hand hit the wrong button. All right, so other things that can give you sensory hearing losses, exposure to loud noises. So when you're in front of that speaker at the concert and it's just blaring and booming and you're right there, that can give you hearing loss as well. I know several flight attendants from being in the back where the engines are, they have lost their hearing because of that. So there's different reasons why folks can end up losing their hearing. Other things, they can have otorrhea. What's otorrhea? Otorrhea. So it's drainage from the ear. Exactly. That's not normal. So that's the reason why we want to make sure we're checking the ear. You can do the tuning fork test, you know, the Weber's or the Rhine test to see if there's, you know, if that sound wave is actually being conducted. So that's a nursing thing as well. So there's certain decibels that, you know, you can determine, you know, how long, or you can do like this with a very small rubbing of the fingers, not necessarily snapping, to see if they can hear it. So there's different ways to see if there is severe loss in the ear. So it can go from slight to profound. When they're getting greater than 90 decibels of hearing loss, then that's profound. So that means that person has lost a lot of their hearing. Depending on the situation, if there's an infection present, then they may have their white blood cells that are elevated. They could do a CT scan to see if there's any abnormality in the vestibular or auditory pathways, or an MRI. They can do that to see if there's any lesions or tumors. The best thing to do is to do an auditory brainstem that evokes a response. So they could do that. They could do a hearing test. Tympanometry reveals if there's any fluid that's in the ear. They can look inside the ear with an otoscope. So there's different treatments that can be done. There's no diet restrictions or activities outside of staying away from loud noises or allowing water to enter into the ear to actually complicate having hearing loss. Any questions on hearing loss? All right. So just kind of think of your interventions that you would perform if someone did have hearing loss, and what would you do? All right, so let's switch a little bit to vision, because that's where we left off yesterday. So if we're looking at vision and you had to do a visual acuity test, where do you want the patient to be from the vision chart? How close or how far? Well, you want them to have 20/20 vision, but you want them 20 feet away from the wall, right? So that way you can assess their vision itself. When do people start actually having vision changes? And I mean, like, you know, where you can be looking at things like glaucoma and cataracts. At what age range? Young adult, middle age, older adult. So about 40 to 50, about around 50. So between, you know, mid 40s and 50s, you want to start doing vision screenings. You know, do you have any trouble with your peripheral vision? Do you have any trouble seeing shapes if you're looking at them straight on? Does your vision seem to be cloudy? So here you want to see if they have any peripheral issues, because that may be indicative of glaucoma. And then there's other things like health history that can actually predispose an individual to glaucoma, which we talked about yesterday, the diabetes, etc. Right? So this is the reason why we want to make sure, you know, is it in their family? You know, is it because they're getting older, or is it because they have diabetes? And that would be reasons for them to develop glaucoma. And we want to kind of get to the root of that early on, so that way they can be placed on those eye drops, right? To help decrease the pressure. All right, so speaking about eye drops, what kind of eye drops would they have? List some eye drops they may be on. Okay. All right, so tell me a little bit about this particular eye drop. Uh-huh. Okay, it's a beta blocker. Yep. What else? So what is its actions? What is it designed to do? Because if you have to, okay, any negative side effects that the patient can experience if they take it? Reduces the ocular fluid, okay. Okay. So we got blood pressure, we got ocular fluid. What else? So if you're going to give it to your patient, so now you need to instill these drops. What should you tell the person? You know, if they say, hey, what is this going to feel like? Monitor for blurry vision, okay? I like that. And don't forget, there's other drops it may burn. Absolutely. So it may cause eye irritation for a few minutes. But, you know, once they can pass that, that is a normal side effect. But continue to use the drops, okay? And yes, it can reduce blood pressure. It can cause bradycardia. It can cause a heart block. It can cause bronchospasms. So those are all different things that this eye drop can do. But there are other eye drops like Diamox. There's Betopic, Lumigan. There's pilocarpine hydrochloride. There's mannitol. There's all these different things that can be used to help minimize. But your timolol is one of the more frequently used medication. So it is designed to, you know, what's its overall design? What is it designed to do? Let me let you tell me. Lower the pressures in the eye. Perfect. All right, so just understand how those drops work, you know, how to instill drops, you know, what should you do, side effects that they can expect to experience, but they still need to take the drops. Can they get some of their vision back? Can they recover lost vision if they start using these drops? It can decrease further loss. So that lost vision, most patients recover some of the lost vision. Doesn't mean everybody will with adequate treatment when they have acute angle glaucoma. So that can happen. That's why I said everybody won't. But they should, you know, seek medical attention if they have sudden vision changes, if they start having eye pain or headache, they need to go back. Okay. All right, what can you tell me about macular degeneration? What part of the eye is affected here? The macula, okay. Is that like the fovea? Okay, the back of the eye, okay. So it's the portion of the retina for which that's responsible for the details of your vision. Like when you're driving, when you're reading, watching TV, it's the thing that brings all those little details into focus. It does affect your central vision. And it involves the ability to perceive sharp, vivid images, okay? So at the center of the macula is the fovea, F-O-V-E-A, which has the highest concentration of rods and cones for the most light-sensitive portion of the macula. So colors, if you start, and some folks are colorblind. Unfortunately, guys are 70% of the men are colorblind, just FYI. But, you know, this is beyond that component. It's like where you can't see the colors unless they're like on the sides of the eye. So if you're looking, they can see it from the periphery, but the central vision is definitely affected. This is an age-related change. You know, it's gray, hazy, blind spots may appear in that central vision. Words may be blurry on a page. Straight lines may appear like they have kinks in them. Colors may seem a little bit dimmer. So you can get blurred vision just from tired eyes. You know, your eyes you've stretched them beyond what they were able to see. So if you try to read like, you know, 4 chapters, and each chapter has like, you know, 20 pages front and back, that's just not going to happen. Your eyes they're going to tire out. Okay. So folks we need to be concerned about that is going to be folks over 60, if they smoke or have a history of macular degeneration. Obese folks, it's usually seen in non-Hispanic whites. So non-Hispanic whites. If they have a chlamydia infection, sunlight exposure, blue or light colored iris. So I guess that takes me up because my irises are brown. I'm just playing. Hyperopia. What's hyperopia? Is that nearsighted or farsighted vision? Hyperopia. Farsighted. So that can also happen. History of cardiovascular disease and, you know, short people. So now I come back into the fold, dang it. Folks with high cholesterol, so that would, and low antioxidants. That's why it's good to have those blueberries and raspberries and, you know, blackberries, because all of those things are rich in antioxidants. And some people actually take vitamins just for their eyes to help with their vision, to not develop things like macular degeneration. So women are at more risk than men. So we're holding this one, ladies. What's the worst case scenario that can happen to folks with macular degeneration? What's the worst case scenario that can happen to an individual with macular degeneration? Not cataracts, blindness. So yes, they can go blind. So this is the reason why we want to make sure we're addressing it. Your book talks about 2 different types, and you can't fix this, by the way. There's no cure. So if you get macular degeneration, it's just a matter of time before you do go blind. The book talks about the non-exudative, which is the dry, right? And it also talks about the exudative, which is the wet. So know the difference between the two. Because the one with the non-exudates is usually difficulty with night vision or changing light conditions. So the loss is gradual in one or both eyes, but usually what they're going to report that there's difficulty reading or driving, or the need for a brighter light or magnifying lens for activities that require fine visual acuity. So changes in their visual field. Where the wet is a little bit more, you know, appears to be more significant based on your book, because you have distortion and loss of central vision, usually in one eye. So there's like a blank spot in the center of the page, which is what I talked about before, where they have to kind of look on the sides, okay? If you don't have any exudate, then you usually see tiny yellow spots beneath the retina, which is called drusen, and some atrophy of the retinal pigment epithelium. If it is wet, then they'll have some fluid accumulation or hemorrhage with grayish green discolorations around the retinal area. So how are we going to treat it? What can we do to treat it? What's our goal with the treatment? Reduce progression. That's about what we can do. So sunglasses, fall prevention, any of the health concerns or risk factors, let's manage those. Stop smoking, eat a diet that's high in vitamin A, C, and E, that beta carotene and zinc. Increase green leafy intake, so those green leafy vegetables like, kale, turnips, collards, they're very rich in carotenes or carotenoids. Your omega-3s, your fatty acids, so fish, eat some more fish, that'll help as well. So that's pretty much most of what they can do. There's a couple of meds. What kind of meds can we give them? There's a couple of meds that they identify. Okay, Lucentis. All right, cool. So if you, have somebody with macular degeneration, just make sure how the room is set up, that the setup is okay. They have towels that meets what their vision needs are. And, fall precautions, those are things that we want to make sure that we're doing for the individual. Visual acuity, we want to monitor that, making sure we do hand hygiene, determine the loss, the extent of their particular vision loss, make sure they have their visual aids. They're going to need their magnifying glasses, they're going to need, or their regular glasses, tablets and computers. All of those things need to be amplified so that way the individual can see what's going on. All right. Questions about not hearing loss, but vision with macular degeneration. Okay. All right. So I think we covered, I think the only thing that's left is cataracts. And we talked a little bit about cataracts yesterday, which is the cloudy, blurred, dim type vision. So you have the pale, gradual visual, painless visual loss, poor reading vision, annoying glare from the sunlight, poor vision in bright sunlight. So, and then how do you, as a healthcare provider, know an individual has cataracts? Cloudy lens, absolutely. So it's usually grayish white that they'll have, when you shine the light onto their eyes. And there's different types of procedures that they can do to treat it. So they can try to break down using the electrosonic probes to kind of break the lens into many pieces that can be aspirated by the probe. They can do an extraction of the cataracts. There's various surgeries that can be used to help treat cataract surgery, lens replacements, and all this other kind of stuff. So if you have an individual that does have cataract issues, and what would be, and they decide to get surgery, what would be some complications that from the cataract removal that you would tell your patient to monitor for? So you have a patient that just received cataract surgery, and now, they're going to have to go home with a patch. The patch is going to be over the eye. They usually do one eye at a time. They have to do drops in the eye. So they have to do that to help decrease inflammation and to help decrease infection. So what would be something that would be a complication related to the surgery? Okay, besides infection, because you're going to actually get eye drops. So not headache. What if the eye started bleeding? Is that normal? Okay. So that would be a complication. So we have infection, we have bleeding. What if they are saying this is extremely painful? Is that normal? No. So those are the key things you want to tell your patient. You know, if they start complaining of severe pain of the eye, they start noticing yellow greenish drainage, or if they start noticing any bleeding coming from the eye, then they need to call that physician or that ophthalmologist that did that surgery ASAP. So, you know, just know what your complications are related to those surgical pieces, so that way you don't, you know, you're giving them the good instructions, making sure they use good hand hygiene, make sure they put the drops on, make sure they follow the physician's instruction as given. So, you know, the dark glasses, you know, don't try to see out of the eye really, really well. You know, I just want to see if I can see. It's like, don't do all that. So make sure those instructions are followed thoroughly, so that way the individual has success with the cataract surgery. And hopefully they went to somebody that actually knows what they're doing, because that would be tragic to have, you know, receive surgery and then you can't really see out of the eye because whoever did it wasn't really, you know, pristine in their care. So questions about cataracts. All right, so make sure they have somebody that can drive them home, because they can't drive on their own, right? Evaluate how independent they'll be able to be at home with this one patch eye, and kind of what the goals are, and ensure that the caregivers are capable of managing, you know, because we're talking about vision. You only get one eyeball per eye socket. So I think I've covered all of the sensory, the eye. Oh, I forgot kiddos. So let me talk about kiddos. Most common sensory issue with kiddos is going to be the ears, more specifically what? Ear infections. Okay, so with ear infections, are they always bacterial? No. So you can have a viral ear infection, okay? And that can be a form of hearing loss because of it. And usually what happens with ear infections is that the individual may have, or the kiddo may have, an upper respiratory infection, and the eustachian tubes, the pressure in the eustachian tubes are unequal. And so that was that serous otitis media that I talked about previously. But keep in mind, for kiddos, you know, they'll pull at the ear, they'll have a fever, they'll have a runny nose, and they don't always need to receive antibiotics. They may just need some decongestant, a humidifier, you know, the saline and blue bulb syringe to help clear that out. If a kiddo has chronic ear infections that go untreated, will they end up with hearing loss? Yes or no? Yes, they can. So this is the reason why they should be treated. Do they need antibiotics? Necessarily, no, but they definitely need to receive some type of medical treatment. If it is bacterial, then it'll be pus on the tympanic membrane, and that's how the physician will know whether it's viral or not. If it's viral, it'll be more red, but it won't have any pus pockets that will exist. Sometimes, because it may be serous, it's just clear yellow fluid that's back on the tympanic membrane. So that's a serous otitis media. So there's different names for otitis media. Ear infection, there's a tympanitis, which is basically inflammation of the tympanic membrane, which is an ear infection, which is otitis media. So, you know, if they do receive antibiotics and they need to take all of it, so that would be some of the follow-up that you would want to, you know, tell them, make sure even if the kiddo starts feeling better, you need to continue the antibiotic as prescribed. So that way it can help eliminate those things, and then treat the upper respiratory infections as quickly as they can. So, you know, based on the kiddo's weight. So making sure that they're giving them weight-based meds for that particular individual. Let's see if there's anything else I want to talk about as reference to hearing. So if they do end up with a hearing impairment, would that be because of acute otitis media, or would that be because of chronic otitis media? It's going to be one or the other. And we're talking about hearing impairment. It'll be chronic, and that's what I just talked about earlier. Okay. So what if your patient is hospitalized and all these alarms are beeping and they're telling you that they can't sleep? What can you do as a healthcare provider to help that individual not have insomnia related to, their environment? What can you do? And the environment would be, alarms beeping, etc. Earplugs would be a good idea. And then maybe setting the mood in the room, so kind of dim the lights in the room to help promote sleep. So yes, Paulette, dim the lights, earplugs, those will all be good things to do. So trying to minimize, the sensory overload for that particular individual. And that is a huge complaint of patients. I heard these alarms beeping all night long. I couldn't get any sleep. So let's kind of think about that part for a little bit. Okay, so we talked a little bit about Crohn's yesterday and diverticulitis. Any questions related to that? So we're pretty clear about, diverticular disease. So what is the difference between diverticulosis and diverticulitis? So otis and itis, what's the difference? Or are they the same? So itis is inflammation. Okay, what's osis? So osis is the pouches. So osis is the weakening. It's the weakening of the intestinal wall for which those pouches form, right? Or those pockets, pouches, pretty much the same. And usually, anytime you're talking about a disease condition, anything on the left lower side outside of ovaries is going to be the intestinal tract, which will be the descending colon. So that's usually the descending and sigmoid area where you would see diverticulosis or itis. And it can be further on, but that left lower quadrant pain is definitely your hallmark sign to tell you, hey, wait a minute, this is an issue. And that this could be one of those differential diagnoses. So, usually that pain, if they have the osis, is intermittent, so it's not constant. But when it becomes infectious, then it's a moderate, dull, steady pain that they're experiencing in the left lower quadrant of the abdomen. Aggravated by lifting or coughing or straining, that would be some issues that they may have. So kind of go back and review that material. One thing I want to, what would be some things that you would tell your patient to avoid? Foods. We're looking at foods for them to avoid. Keep going. Nuts and seeds. So anything that have nuts and seeds in it. So although they're indigestible, things like nuts and seeds may become lodged in those pockets or pouches and start the inflammatory issue from going from diverticulosis to diverticulitis. So tomatoes, kiwi, cucumbers, those will all be some of your seedy vegetables that, or fruits that you want to stay away from. So any nuts, sesame seed, I can see it, but I can't call the names. The little black speckly ones that can be on your bread. Those, chia. So all of those can get trapped in there, and you know, poo's going to get trapped in there, and it's just going to be an inflammatory process that's going to brew. Poppy seed, that's the one I was thinking. That's the one that I was talking about. I was like, I could see it on the bun, but I just can't call the name. So they need to, you know, sometimes they require IV fluids because the gut is, when it's itis, you know, they have to relax and rest the gut, etc. And then they will start them with a clear liquid and graduate as tolerated. But what are some things that they can do in their diet to minimize, you know, the development of diverticula that we talked about yesterday? High fiber, definitely. So they need to add some more fiber to their diet. Other thing, they can, if it is itis, high fluids, absolutely. If they do have the itis, they may be on antibiotics. So they're taking that as prescribed. The main one would be Flagyl. They can also get Augmentin. Augmentin, you know, you got to be careful because some people it gives diarrhea, so we don't want to have that happen. Bactrim, so that's another one. Ciprofloxacin. Those are all different antibiotics that the individual can receive to help treat diverticulitis. Think about measuring the abdomen to make sure we don't have what if our abdomen was hard and firm and large, or, you know, the girth has gotten bigger, should we be suspecting at that particular time? Perforation, absolutely. So just, you know, just kind of a recap from, you know, what we talked about already in relation to elimination. But just wanted to kind of see if you remembered that. Crohn's, remember that was another one, because you can also have inflammation, you can have bacteria, but that's that slow progressive inflammation of the intestinal tract, right? And, you know, Crohn's can cause you to have a bowel obstruction or paralytic ileus. Usually most paralytic ileiuses happen after surgery. So that's the reason why we want to get them up and passing gas and all those good kinds of things. All right, so we talked about skip lesions as being one of the signs and symptoms that you may see, right? And the individual may have, you know, marked periods of remission and exacerbations, fever, flatulence. Is this considered an ADA condition, American Disabilities Association condition? What do you think? Would this be considered an American Disability Association condition? And the answer to that is yes. So if there's a person that works in your establishment and they have ulcerative colitis or Crohn's, their desk has to be very close to a bathroom that primarily they can use at will. So that's what the establishment has to set up for them. So they can't be walking, you know, all the way to the other end of the hallway. It literally has to be within so many feet of their desk. Other things to you are correct that your book is now saying there isn't any. Paulette raised the question that the book is saying that the patient doesn't have to avoid nuts with diverticulitis. That is true, but if you look at the recommendations for what you tell them at home, they still encourage them not to eat things that have nuts in them, nuts or seeds. They haven't found any research. However, if you look at what they tell them for discharge planning, they encourage them not to eat those foods. So you are correct with that. Let's see, back on Crohn's, are those the ones with the skip lesions? Yes. So they can, what type of nutritious or nutrients that you need to consider if they do have, you know, Crohn's? We talked about this yesterday. Malabsorption of those B vitamins, every one of those B vitamins. So B12, folic acid, you know, those they would need to replace those because those are primarily absorbed in that ileus. Potassium, calcium, and magnesium levels may be decreased because of the diarrhea. So, you know, if they have an infectious process, then their white blood cell is going to go up. If they have inflammation, their C-reactive protein and their estimated SED rate may be elevated because of that. Their albumin levels will be low because of the protein loss that they may have had from not, you know, from doing all that evacuation. GI studies like an endoscopy, a sigmoidoscopy, or a colonoscopy, all of those would be things that they would use to identify, you know, how bad this particular situation may be. They could do sitz baths because if you're having that many diarrheal stools, then you're going to be a little raw in that area. So things to avoid would be foods that worsen diarrhea, raw fruits and vegetables if blockage has occurred. They need to have adequate caloric intake and protein intake and vitamin intake. Decrease fat or fat malabsorption, so avoid dairy if they're lactose intolerant, and try foods that are bland, so that brat diet, bananas, rice, applesauce, and toast. We did talk about medications, the antispasmodics, that they could actually have, the sulfasalazine that they could use, the proton pump inhibitors, Flagyl, that would be another one. So there's all different types of medications that may be utilized to help treat a respective flare-up or exacerbation of Crohn's. With surgery, they could do a colectomy, they could do a strictureplasty, they could do surgical repair of recurrent fistulas. So there's different types of surgical procedures that can also help with Crohn's disease. Questions about Crohn's? Any questions about elimination? Don't forget about neurogenic bladder. Don't forget about that. Making sure that they use a bladder schedule to, you know, to help facilitate, teach the patient how to do a self-catheterization. So all of the tangibles related to that. You know, drinking fluids to help train the bladder, Kegel exercises to help, you know, make that pelvic floor a lot more stable. So it's kind of coming together for you guys. So there's a question about why isn't Crohn's discussed and not ulcerative colitis? I don't really have a good answer for you related to that. Sometimes we do talk about it, but since it's not in your exemplar, I don't want you focusing on it. CBC has actually moved both conditions to 4th level. So this will come back up again in 4th level. So, I mean, I guess from them, they were looking at the bowel obstruction process. I don't know. But yeah, we didn't understand it either, but they have decided to move it to 4th level. So when you get there, guess what? You'll get Crohn's. At least you'll have a good idea about it. And then they'll now add in ulcerative colitis. So, any other questions about the elimination component? All right. If not, then the one last thing, I think I'm trying to make sure I don't miss anything on eyes and ears and all of that. The one last thing I will say is just corneal abrasions. And, you know, that can happen a variety of ways. A gust of wind can blow and a speckle of dirt can fly right in your eye. And you can end up with a corneal abrasion. There's other methodologies that, you know, this can happen through chemicals, through thermal burns, through contact lenses, foreign bodies that are embedded underneath the eye. First things first, making sure as a nurse you get a visual acuity on the patient, right? So don't be like, oh, I don't know, I don't want them to hurt their eye. We need to know if this has impacted their vision. And then they're probably going to do like a slit lamp test. So they're going to stain the eye, look and see if they can find the abrasion. Sometimes, you know, depending on what it is or where it is, it will have to work itself out But they do give NSAIDs, topically, antibiotics like gentamicin is an ophthalmic drop that they're normally given to help with minimize the potential for infection and then for comfort measures. So, you know, try not to have them, you know, move the eye any more than what they need to, but know how to instill, you know, your optic drops. Some people will use Morgan lenses to help flush the eye to see if they can flush it out. So most people would have done that already. I've had one corneal abrasion. I can't even tell you how I got it. I just noticed that my eye was irritated and it was hurting quite a bit. And I was due to fly out of town the next day. And I said, no, this can't be. So, you know, it was what it was. All right. So let's see, I covered all of that. We talked about the intestinal obstruction through the paralytic ileus. We talked about that yesterday, correct? And then make sure you know the different types of obstructions, like if it's mechanical versus non-mechanical. Mechanical would be more of your adhesions from previous surgeries. And I have heard more stories than not for which folks are dying behind adhesions from surgery they received related to small bowel obstructions. So they had a small bowel obstruction, they had a small bowel obstruction repair, and then they've had adhesions develop later on or throughout their life that has literally run amok on their intestinal tract and caused them to actually die from those adhesions because it caused them to have dead gut. Other things that can be a mechanical obstruction would be like colon cancer, when the intestines loops or twists on itself, then that can also cause mechanical obstruction. Barium impaction, strangulation of the hernia or of a hernia, that can cause a mechanical obstruction. Non-mechanical would be electrolyte imbalances or paralytic ileus, and that's where there's no peristalsis, so nothing's moving. It's like, you know, the intestine just said freeze and nothing moves. So it just stays where it is, and then it just creates more havoc into the intestinal tract. So, you know, keep in mind about your electrolytes and how they will be impacted. So, you know, like your sodiums and your potassiums, they'll be decreased because the patient will be vomiting. How your amylase test will play a role into it. That may increase if the pancreas is irritated by the bowel loop. BUN test, you know, that may increase if the patient's dehydrated. So pay attention to your electrolytes, and then, you know how to recognize it and how to treat it. Questions. I think there was a few questions about left and right heart failure that started in the beginning of the conversation. So we can address those. I don't have an issue with that. So if you have left-sided heart failure, usually that person's going to, it's usually in relation to like someone who's had like a heart attack or someone that has high blood pressure that's gone untreated. They can develop left heart failure as evidenced by Rales and JVD, jugular venous distension. If they have right-sided heart failure, sometimes right-sided is due to left side, but not always. You can have right side by itself, and basically everything on the right side is congested. So you'll have your liver is going to be enlarged, your sacral area will have edema, your belly will now be in edematous or swollen because it's full of ascites. You have dependent edema, so both of your legs can have that. And then you have on the flip side of that, the spleen. The spleen will also be edematous, so, or have splenomegaly. So does that make sense? And you were supposed to go to the presentation on Tuesday. So they should have, with my understanding, covered that completely. So did they not? Okay. Okay. So so just, keep in mind that those things, that in all of that perfusion, you got to go back to your lab values, your HDLs, your LDLs, your triglycerides, your cholesterol levels. So you got to go back to those things, your BNP, know how if you give somebody, like something to decrease heart failure, then how do you know the medication is working? What assessment would you do? You would auscultate breath sounds to make sure there's no more rails. So you need to make sure that, they should have discussed all of that during the perfusion. And so I don't want to spend a whole lot of time on the whole perfusion component because we've focused on that so much. I don't want you not thinking or focusing on your sensory, your sleep, your all of the eliminations that we talked about. So I don't want you thinking that that's going to be downplayed, because this is going to be a 50-50 from, perfusion, and then 50 for the rest of it. So, I don't want you thinking that, hey, I only need to know what, this perfusion because they're focusing on it a lot. You need to understand what preload and afterload is, because they may ask you something, and it may not come up on exam 4, but it may come up on your comprehensive, what's preload, what's afterload, and how does it play a role with cardiac output. So you still need, you need to understand that globally, regardless of whether it's asked on this particular test or not. I hope that makes sense. So, you've had some time to really focus on it. You didn't have class for 2 weeks for me, but if you've been digging into the exemplars and digging into the raising the bars, you should be A-okay for the test, because you shouldn't have too much struggle on that. But yes, to someone, Paulette, JVD is right-sided heart failure. So you asked that question. So yes, you're correct. Just hopefully you've been doing all those things already, and you don't get to the test and freak out. So here's this will be my advice for you guys for tomorrow. I would, you should be kind of wrapping up right now the studying. What I've provided over the last couple of days should really be review if you've been doing the raising the bars. I've kind of given you some Q&As just to see where you are. You did the case studies. So you should kind of be ready for the test. Read one question at a time. Take your time. Read the question in its entirety. Don't think you know what the question is really asking you. Make sure you know what the question is asking you. And once you do that, that should help you figure out how to answer the question. So if you already know that, highlight stuff in your vignette. They have a highlight button. If you don't feel comfortable doing the highlight button because you don't want it to click to the next question, then okay. Then you get a little scratch paper, right? So then just kind of write some things to yourself in your little cubby corner thing, so that your classmate to the left and right of you can't see it, but it helps you stay grounded. And if you think the noise is a factor, then bring you some earplugs and put them in your ears so you can only be with your thoughts only, no matter who's going in and out of the room, or you don't have to get focused on any of that. So just, don't forget about your ECG rhythms. You got to know your basic ECGs, what's sinus tach, what's sinus rhythm, what's V-tach, V-fib, asystole. Those are your basic ones. Know what you need to look for, your rules. So, is there a P wave in front of every QRS? Is, the PR interval, between 0.12 or 0.16 and 0.20? Is your QRS complex less than 0.12? So that would be, that's how it's normal sinus rhythm. But no matter what you're doing when you're trying to identify what your rhythm is, that's still the same process you're going to use, because it's going to tell you where you need to move if it's not within that realm. So, you know, how do you count your strips going from R to R intervals? Is it consistent? So is your R consistent? That, you know, it has to be consistent. So all those things that we've talked about, you know, between, you know, since exam 3 and all the way up until today, you know, you've had some time to really, you know, put some stuff into it. So hopefully you've been doing your due diligence and then getting ready for your comprehensive exam, because you guys have a quick turnaround for that. So after this exam 4, you know, and that grade drops, then you need to start looking at, you know, if you're going to retake a test and, you know, submitting that documents, but you're still prepping for comprehensive. So you should have received the little study guide that I sent out, and hopefully that's extremely helpful. When I talked about the P&C stuff, that's for HESI. No, we don't have class Tuesday. So that was for HESI, about the P&C, I mean, about P&C, because you will have P&C questions on HESI. So I don't want you escaping those thinking, well, we're not going to be asked any questions. Yes, you are. So that was the reason why I wanted to make sure you understood that component. So if you don't have P&C this semester, then you need to go back and look at those P&C concepts, because they're going to be on HESI. Make sense? All right. I don't know what else I can do for you. I don't have the test, but I mean, I can tell you some things you need to kind of think about. What was it in reference to, Latricia? I know I haven't looked at that particular. Was it for P&C? Where was that? The SNS was central nervous system. I mean, sympathetic nervous system. Let me see if I can find the study guide real quick. Hold on. All right, I just found the study guide. Hang on. So, I'm going through real quick. Hang on. I'm logging into the P&C side just to make sure I don't give you the wrong thing. Because that would be tragic. Let me find P&C. So this is what I'll do. I'll find it real quick, and I'll just send you guys an email of what the abbreviation is. So that way you can focus on that as you go, and you don't have to sit here and wait for me to find it and then give it, but I'll make sure that I send it out. Someone asked about points being given to overall grade. The answer to that is no. So there's no points to be added. What will happen is if you, even your collaborative points, they won't get added until you have successfully passed the entire course. So there's no point boosters or anything like that. I can't say we per se got tagged for that. They consider that grade padding grades, but that's the reason why we looked at our collaborative points to make sure that it didn't pad grades. And that's why no matter if you get an A, B, or C, you get 1 point. Before, if you got an A, you got 3, a B, you got 2, and a C, you got 1. But if you got an A on the course, that could be a potential of, 12 extra points added to your grade. So they've eliminated that process and made it fair for everybody. So the max points you could get is 4. So does it help your grade a little bit? Yeah, but it doesn't pad as in the other score. So even if you were making a B and you got 12 points, that can move you into an A. So a lot of schools have been, minimizing even collaborative points. So right now we do keep them around. So that's one good thing. There may come a time where it doesn't say that. There's no grade for the case studies. Those case studies, because if there's a complaint to say we didn't have class, then I have case studies. This is why I had you turn them in to show this is what I did. And I have these Zoom sessions that are recorded to show this is what I provided in lieu of not having class on those 2 Tuesdays. So that's the reason why you had to do those case studies. So it wasn't like it was a free day and you didn't have any instruction. So you had instruction face-to-face, and you also had instruction where you were actually doing case studies in preparation for the exam. So there's no grade for that. Any other questions? Okay. You asked me the same question, Paulette. I mean, I can't give you points for that. So, but before I did it, I talked to Dean Becker. Hey, that's what I did. I'm sorry. But look at it this way. You should be more prepared for your exam, and you should be ready to go. So, go out there and slay it, and in a good way. All right, guys, enjoy your Sunday, and we'll see you tomorrow.